Good evening, and thank you for joining us tonight. My name is Corinne, and I will be your moderator. Tonight's webinar is a part of our Breaking Down Barriers series, and our mission is to shine light on areas of dentistry that are overlooked by many and increase awareness to help achieve optimal oral health care, which is a critical component to achieving good overall health. We are excited to welcome Dr. Seena Patel as our first speaker tonight. Dr. Patel will be providing insights on what you need to know about the dental provider's role in the journey of cancer treatment. Tonight's webinar is the first of two on this specific topic, with the next webinar happening later this month. Everyone registered tonight will have access to attending that webinar as well. If during the webinar you have questions, please drop them into the Q&A section of your control panel, and we will answer them live at the end. All right, let's get this show on the road. Dr. Patel, thank you so much for participating in this series and covering tonight's topic. I'll hand it on over to you.
All right, thank you so much. Good evening, everyone. I appreciate you attending this webinar that's really very close to my heart. I'm very passionate about helping people through their cancer treatment, being the dental provider for them. And I hope to be able to shed some light on any particular questions you guys might have. And with that, let's go ahead and get started. So as the title of this presentation states, we're going to go through the various steps that the dental provider might encounter when the patient begins their cancer treatment journey. As you all know, cancer is an extremely devastating disease. It ends up causing a lot of physical, emotional, and social implications. And so we are one part of the team that this person is going to see. So let's get started. I have received financial contribution from Henry Schein Dental for this webinar, so that's my one disclaimer for this. And as I mentioned, we're going to explain the necessary steps requiring for rendering appropriate dental care throughout 3 phases of cancer treatment: before they start, while they're going through it, and afterwards. And then I'll also describe some ways that you can help your patients prevent oral disease while they're going through their cancer treatment, along with well after they are finished with that. And then at the end, we'll touch on some oral complications of their cancer treatment and how we can help manage them and prevent them. So a little background here. In 2021, it was estimated that there are about 1.9 million new cases of cancer in the United States. And there was an estimated 608,000 deaths due to cancer. So with these kinds of numbers, it's without doubt that the dental professional will be seeing several patients through some phase of their cancer treatment journey in their practice. And so we need to be well prepared to help these patients. And I put this citation down here for further information, but we get a lot of good statistics from the American Cancer Society websites. And if we go through all the different cancers that there are, these are the top 12 most common cancers. And as you can see, breast cancer accounts for most of them. This is the most common cancer. And then we're followed by prostate cancer, and we can see the discrepancies between males and females. And then after that is lung cancer and bronchus cancer. So of all the patients you'll probably be seeing, these are the things you'll come in contact with. And then, of course, there's always exceptions to everything. There's rare things you're going to see, but you can implement these principles we'll talk about for all cancers. It is a highly prevalent disease, and it seems like the prevalence just keeps increasing over time. So what are the usual types of cancer therapies? Of course, you might see patients go through just one of these treatments. You might see them go through all of them, or some combination of a few of them. When the anatomy permits, or if the cancer size is limited in size, most patients will undergo some type of surgery. Chemotherapy, as you probably already know, is as a type of medication administered to the patient in efforts to kill those cancer cells. Unfortunately, we know that chemotherapy also attacks a lot of our normal cells too. So that's why there's so many side effects to it. And then patients go through those complications too. But of course, the end result is to adversely affect the DNA synthesis of the cancer cells or protein synthesis, and ultimately destroy those cancer cells. What probably you've been seeing more of lately, and you will in the future, is immunotherapy or some type of targeted cancer therapy. Immunotherapy is based on the premise that the immune system plays a really complex role in recognizing and fighting cancers. When there's a tumor, it has the capacity to evolve into evading the immune surveillance of our normal immune system. So the tumor now develops cellular changes that find ways to escape our own immune attack against that cancer. So now there are a variety of medications that are implemented to target those specific immune checkpoints, and it helps to target the cancer in that way. And targeted cancer therapies, we'll talk a little bit about that later so you can see the oral implications of that, but it's a similar premise where they're just more specific types of cancer therapies. So they're different from chemotherapy in that way, but it's all in the premise of precision medicine. So it's really fascinating that these oncologists, look at genetic changes or mutations and things like that specific to what cancer that patient has. And then there's these medications that are actually just for that specific type of cancer. Radiation therapy is a much more familiar concept because it's used in a lot of different types of cancers. We're familiar with head and neck radiation, and that's going to be in the series 2 of this webinar series that we'll go into more. But radiation therapy essentially uses high radiation doses, usually over 50 grays, to kill cancer cells by damaging their DNA and chromosomes that are required for their replication. And it's usually used, it could be used alone, it could be used as an adjunct to surgery or chemotherapy. So you might see a combination of those things. And then the hematologic malignancies or patients with certain autoimmune disorders or primary immune deficiencies, they may undergo this type of treatment, which is the hematopoietic stem cell transplantation or the bone marrow transplant. Which the premise behind that is that the patient's body is going to be conditioned, and then the intention is to destroy the bone marrow and then replace it with a functioning normal bone marrow. And as you can imagine, that also comes with a whole host of oral implications, oral complications. So the usual diseases that are treated by HSCT are leukemias, aplastic anemia, myelomas, as I mentioned, autoimmune disorders, and primary immune deficiencies. And the 2 most common types of those are the autologous HSCT, which is the patient's own bone marrow is preserved and then transplanted back into them, or the allogeneic, which is from an HLA matched person. It could be a related or unrelated person. So where does the dental provider come into play here? And there's several different aspects of where we are joining this patient on their cancer treatment journey. Of course, first and foremost is screening and recognition. I think that most of us are really well aware as to why it's so important to perform oral cancer screenings or head and neck cancer screenings. It's really important to take a thorough medical history. You can always, even if it's not a head and neck related cancer, but we're just taking their medical history, certain questions can, allude to either previous cancer or maybe something that's a red flag for us. So, just even simply asking a patient, has your health changed in the last year that we've seen you? Or have you ever had any changes like lumps or bumps, that you've noticed in your neck, in your arm, something like that has no reason behind it. So have you had any other kind of pain or neurologic sensation changes, things like that? Of course, you can go through your large review of systems list, but the most important thing is asking the right questions and then performing your head and neck cancer screening. And then we'll go through steps 2, 3, and 4 as to what is really necessary to know and complete before, during, and after cancer treatments from a dental standpoint. We'll go through some prevention of oral disease. We can't emphasize this enough. Obviously, we're dentists. This is what we live for. But in the cancer patient, prevention of oral disease is much more important. Studies have shown that the reduced oral like biofilms, oral infection, oral disease, reducing that before their cancer treatment starts does improve survival outcomes and, of course, oral complications. So it improves quality of life, but it actually does improve survival rates as well. So this is really important because the patient will be immune suppressed during their treatment. And then, of course, any kind of infection could potentially lead to bacteremia, septicemia, and that kind of thing. And then lastly, we want to be there for the patient for any oral complications, as these are highly prevalent in this population. And so the NIDCR and the American Head and Neck Society, they do have statements that say they recommend seeing the dentist prior to head and neck cancer treatment. But the British Association of Head and Neck Oncologists actually recommend that every oncology patient have a dental assessment prior to. And most cancer centers agree that it's very important before their patients start the treatment to have them see a dental provider. So what are some oral manifestations of cancer? In this talk, we're going to focus on the general cancers and not head and neck cancer. Again, that's going to be in the second webinar as part of this series. But there are a whole host of other oral manifestations besides oral cancer that show up in the mouth. On the top left here, as you can see, this was a patient of mine in my private practice, and she was a 77-year-old female. She had a history of lymphoplasmacytic lymphoma. She told me that she was in remission, she's not undergoing treatment. But she says, since this was a few years ago, so at the end of 2019, she said, you know what, I'm just getting these swollen gums. I've seen my dentist, I've seen my periodontist, I was sent to an oral surgeon. They took a biopsy, but they sent me here too. And she just was in a lot of pain. As you can see how swollen the gingiva is. But what's harder to appreciate is there are these linear ulcerations right in the vestibule here. And so this lady was really having a difficult time with her mouth, as we can imagine. She tried 5 different antibiotics, prednisone, aloe vera juice, 2 antifungals, magic mouthwash. Most of the time, by the time I see the patient, they've gone through a good list of treatments beforehand. So then her oral surgeon had performed the biopsy. We were still waiting for the results. But once we got that, it actually had the results showed plasma cells, but suggestive of further evaluation of her systemic condition. And so since we knew she had this condition, I got on the phone with her oncologist to let them know. It turns out it wasn't exactly that she was in remission. It was more that she had refused treatment. So that helped me understand a little bit about her status too. So if you guys might have heard that lymphoplasmacytic lymphoma is also called Waldenstrom macroglobulinemia. So it's one of those things that, they have various treatments, chemotherapy for that. But after discussion with her oncologist, the only real treatment at this point was to manage this hematologic malignancy. And then you can see improvement in the oral condition. So we both had to really encourage her to continue with the oncologist's plan. Okay, so then the next case, which I found was very interesting, was a more recent situation where a patient of ours had a history of multiple myeloma. He'd been in remission. We'd been seeing him since 2016. And, I went back and looked at all the imaging, and you couldn't see anything in the jawbone and the panos and things like that, CBCT. So he comes for a limited exam. You can see this swelling here. It was actually quite firm. He was in a lot of pain, and we could definitely see there's some oral hygiene issues as well. But when we took the periapical image, you see this nice large radiolucency that's there along with this swelling. And of course, I get worried because of the history of multiple myeloma, though he said he was in remission. So, but one thing led to another, and we kept in contact with the hematologist oncologist, and you can see a drastic difference from his labs just from September of 2021 to December. So something changed dramatically. And so he actually ended up being hospitalized for the cancer treatment and then was treated. And we're still kind of awaiting to see what's going on. But his pain clearly wasn't related to an odontogenic problem. And I'll show you some imaging of that too. And then, as you probably are more aware of, especially from your dental school days, like we always remember that being taught that leukemia can definitely have leukemic infiltrates in the gingiva, and you can have this like swollen, really erythematous, sometimes ulcerated gingiva. Leukemia can also show up as this kind of persistent ulcer on the tongue. Of course, we can see melanoma in the mouth, extremely rare, but it can happen. And this was a patient from many years ago, actually, that I'd seen with my attendings. This was when I was in training. And the patient had adenoid cystic carcinoma. She'd had this large lump on the tongue for a long time. And so we took an incisional biopsy and it came back as that. So the point being is that there are many cancers and we can have oral manifestations. What about the radiographic manifestations? So we can't neglect the fact that metastasis can happen to the jaws. So any person, in my opinion, who has a history of cancer and you see something unusual on the radiograph, of course, most of the time things are odontogenic, but we have to remember that we have to be a little bit more careful in the patient with the cancer history because to rule out metastasis. And this was the patient I was telling you about just earlier with the multiple myeloma. So you can see we took a CBCT and you see this large radiolucent mass. That's really, you don't see these well-defined borders, which is always suggestive of a more ominous source. And you can see this large lytic lesion on the pano. And I went back and looked at several imaging that we had, and I noticed this was just recent in the past from 5 years ago. We didn't see any of this. And so, some of this could be from past, some patients with multiple myeloma could be from past illness, and even if they're in remission, they may still see those lytic lesions. At least I was told. But nonetheless, being that this is a new thing, it's of concern, obviously. And here's another lytic lesion. This was in the most recent CBCT. So various things that we don't get to see every day, but it's definitely an interesting learning experience. Okay, so let's talk about the steps involved with pre-cancer treatment. So most of the time, if the cancer is amenable to surgery and it doesn't directly affect the oral cavity, that's all they're going to get, then generally, that's not going to really make any big change in their usual dental treatment. You can render dental treatment just safely without any further precautions. However, if they're going through chemotherapy, immunotherapy, targeted cancer therapy, radiation, or stem cell transplant, then all these principles apply to that. So the first step is figuring out what the type of cancer is, what's the patient's stage and prognosis, and what's their cancer treatment regimen. And then the next question, if this is a head and neck cancer, we want to know if they're going to go through radiation for that as well. That's going to impact the type of treatment you render. And the other part of this question is, will the patient be administered chemotherapeutics for the cancer, but also that pose a risk for osteonecrosis of the jaws and or oral infection. If someone's given chemotherapy, it's kind of a known thing that they're going to be at risk for infection. And then the next part of that is, of course, as we do with all our patients, we're going to do a comprehensive oral exam and radiographs. But the main key point for the cancer patient is to really figure out is there any active oral disease that could be exacerbated during their cancer therapy. And it provides for a baseline assessment. So you're going to be seeing this patient very regularly, lifelong. So that's why it's so important to figure that part out. And then, of course, like I mentioned, prevention is key here. So let's go through a case study here. This was a 24-year-old, and she comes to your clinic for a dental clearance. She tells you that she's referred by her oncologist to have a dental clearance before she starts cancer treatment. And her medical history is acute lymphoblastic leukemia. She's otherwise healthy up until now, doesn't take any regular medications, doesn't have any allergies to any medications. And unfortunately, she hasn't seen a dentist in 10 years. So she hasn't had regular care. The planned cancer treatment is chemotherapy and HSCT, hematopoietic stem cell transplantation. So we do our exam, we do our radiographs. I've kept it brief here so you have the pertinent findings. But you can see that number 19 has a large carious lesion approximating the pulp. The radiographs show a periapical radiolucency. And then we've got incipient caries on 2, 3, 14, 15, and 30. These are interproximal. Certainly we see severe gingivitis, heavy plaque and calculus buildup because the leukemia has affected the gingiva. So these are all leukemic infiltrates. So the patient is experiencing obviously very easy bleeding. It's difficult for hygiene in this case, so that just exacerbates everything. And she does have her thirds present, but they are otherwise they're not partially impacted or partially erupted, so they're otherwise intact. Okay, so we've got this case. We know what her cancer treatment is, so that's great. We know what her diagnosis is. Some other things we'd want to know is, what's her prognosis? We'd want to know the timing of her cancer treatment. When is she going to start? And these are the specific components of her pre-chemotherapy and pre-HSCT oral evaluation. So for any patient who's going to be starting chemotherapy and or hematopoietic stem cell transplantation, these are the things you're going to go through. Ideally, it would be great to see the patient 2 weeks before they start their cancer treatment. In the real world, it's not always possible. So we're hoping for 2 weeks. We're okay with 1, and then we do the best we can. As I mentioned, the patient who's going to be going through this immunosuppressant phase of their treatment, which is what the chemotherapy is going to do, the stem cell transplantation is going to do, because they'll go through conditioning, chemotherapy conditioning before they get a transplant. So of course, eradicating any source of active infection is of paramount importance. So you want to figure that out. Their mouth is going to be really sore throughout treatment, really dry, really friable. And so if there's a traumatic area in the mouth, like a fractured cusp or something, and it creates an oral wound, that becomes a portal of entry for bacterial organisms to then become systemic. So that's extremely important. And in general, we say if the tooth has a fair or poor prognosis, we recommend being a little bit more aggressive here because of the risk of further disease in that tooth later on. We don't want this exacerbated during or after cancer treatment, so we say extract. And when possible, it's extremely important to do the periodontal therapy, the prophylaxis, debridement, to get any source of bacterial organisms and infection treated prior to. And fluoride treatments, of course, are of utmost importance here too, because of the risk of xerostomia that would increase their risk for caries. The one thing I always like to hone on is realize the effect that the chemotherapy and the patient's hematologic malignancy. So if the patient's going through chemotherapy, let's say for breast cancer, well, the chemotherapy is going to impact the patient's hematologic and immunologic status. If the patient, like our case, who has a type of leukemia, that is already a type of hematologic malignancy. And in and of that type of disease, the nature of that disease, you're going to see altered platelet counts, altered white cell counts, because it's a bone marrow disease, right? So that's really important before we begin anything, because we want to know their hematologic status. For a patient who doesn't have a hematologic malignancy and just got newly diagnosed with this type of cancer, but it has not yet started chemotherapy, then of course we expect their labs to be normal because they haven't received the chemotherapy. But we do want to keep this in mind, because obviously everything we do is going to increase their risk for bleeding and infection. So before we start, we want to know that status. A long time ago, it was thought that oral bacteria could potentially cause bacteremia and central venous catheter infections. However, the most updated guidelines state that antibiotic prophylaxis is actually not necessary for those who do end up having an indwelling central venous catheter for their chemotherapy. So that's something really important to remember. Those kinds of catheter-related infections, they're usually not from oral bacteria. So that's something that's an updated guideline. We also recommend that patients don't wear their removable appliances during chemotherapy. And that's because just of the oral irritation, and then it potentially makes it very uncomfortable, and it's a source of trauma. And then I always spend some time counseling the patient on all the oral side effects that can happen from chemotherapy, ways to prevent that, same with HSCT, and focus on prevention. What can we do to help and also minimize oral discomfort throughout their treatment? And for anyone who's interested too, the MASC ISO guidelines, they provide a lot of great information to expand upon a lot of this. There's a whole group of professionals who are updating all of these oral oncology guidelines. So all of this is coming from that. So when you're going to do your medical consult, and when a patient's coming to you for for dental management prior to cancer therapy, you're going to be in close consultation with their oncologist. You want to figure out, like I mentioned before, what type of cancer and stage is it? What is their exact regimen? We want to find out, are they going to be administered a bisphosphonate or a rank ligand inhibitor or some other anti-angiogenic medication for their cancer, because that will put them at risk for Amrange. Some people already, they know this is going to be curative or it's just palliative. Maybe the patient's prognosis isn't very good. That's going to impact the type of care you provide as well. So that's why we want to know all of those things. For those who have a hematologic malignancy, before you start any kind of treatment, you want to ensure you look at their labs. So that's going to be the complete blood count with differential and platelet count. And that's because we want to know, is their absolute neutrophil count high enough that they're not at risk for a significant bacteremia or septicemia from our dental procedures that can cause bleeding. And of course, our platelet count, we need that to be in a good range in order for that patient to obtain adequate hemostasis. And even a simple prophy can cause severe bleeding in a patient with leukemia. So we need to know that beforehand. The general guidelines are that if the ANC is less than 1,000 for more than 7 days, then antibiotic prophylaxis would be recommended. And most of the time we follow the AHA 2007 guidelines for that, but when unsure, sometimes the oncologist wants specific medications too. So we consult with them as well. The platelet count has to be above 50,000. If it's lower than that, you're probably going to be seeing yourself in a hospital setting, working with this patient, or finding out a way to see if a platelet transfusion or something like that is necessary. So I always say these are the 2 red flags. Is if we're out of range here, we just say stop, let's get some information. And then we want to know the schedule of treatments too, because some patients will be receiving chemo for a while and they may need dental care in between. So we want to know the timing to know when we can more safely provide care. For the patient who's going through an HSCT, you ask very similar questions. Most of the patients will go through like total body irradiation. Usually that level of radiation is not as high as it is for head and neck cancers. So the risk for osteoradionecrosis is still a lot lower than it is for those receiving head and neck cancer treatment. However, we still need to know, where is it just going to be like, what is the dosage of radiation that the patient's going to go through? Of course, they're probably going to go through some chemotherapeutic regimen to condition their body prior to the transplant. And in general, once you consult with the physician, we can get a general idea of what their level of immune suppression is. When we look at their labs, that also helps us assess that. So it's the same concept here too. You're really looking at these 2 critical labs, the absolute neutrophil count and the platelet count. I would say that before seeing a patient starting cancer therapy, if I saw someone who just, who had like, for example, breast cancer, but was going to start chemotherapy versus someone who has leukemia, like in our case, I'm much more concerned about the bleeding and infection risk for the patient who's going through hematopoietic stem cell transplant because they have leukemia or some other hematologic malignancy that's already altering their blood counts. Whereas the patient with breast cancer has not yet started with chemotherapy. So their labs are probably going to be normal. So this is a much more tender population. Now, I just wanted to touch on this, give you a little initial information, but we're going to talk a lot more about it in the second series with the doctor who's presenting that topic. But for the pre-radiation oral health evaluation, same kind of thing. Ideally, we'd like to see them 2 weeks before they start. We see all of the same principles for chemotherapy apply here as well, where we want to address every site of active infection, eliminate any sources of trauma. But our attention, of course, with the cancer patient is figuring out what the most immediate concern is. And that's because you generally won't have time to do comprehensive care. You want to, stay with the phase 1 treatment and get them ready for their cancer treatment. And then anything elective can wait after they're done. Generally, we say prophylaxis, periodontal maintenance, and debridements are elective, but I like to say not really in the cancer patient, because if they have active periodontal disease, and then this does increase their risk for oral complications during cancer treatment and potential bacteremias and infections later on. So we really want to get this done when possible. For the radiation patient, the radiation can actually cause trismus. So it can cause fibrosis and contracture of their masseter muscle or their masticatory muscles. So it could be the medial pterygoids, the masseters. So you want to establish a baseline jaw range of motion, and you want to teach them stretching exercises. So we always document that in every patient who gets head and neck radiation for a head and neck cancer, because that level of the dosage is so high that it can potentially cause limited mouth opening. And then we want to make custom made fluoride gel carriers as well. And we always inform the patient that fluoride a prescription strength fluoride treatment is going to be a lifelong thing for the patient who receives head and neck radiation. The risk for radiation-induced caries is so high when these aren't used and when oral hygiene isn't optimal. It can be quite dramatic. You'll see a change within even as short as a couple of months, 1 month. So these really make a difference. And then the same premise is we emphasize prevention of oral disease, and we'll go through the complications of their treatment. So in the medical consultation with the patient who's going through radiation therapy, we want to find out what their stage is, when are they going to start. Most of the time the oncologist will probably give you a start date, but they usually say, okay, but during maybe a week after that start date is when they really start radiation, because their start date will probably be the simulation. So sometimes you have some wiggle room to get that, but that knowing when they're starting is really important, obviously. And of course, we want to know the field of radiation. Dr. Epstein has done a lot of work with head and neck cancer patients. And in his book, he has this diagram, and it's from 2008. So things are rapidly changing in technology in medicine, as we know, and dentistry. But I like to refer to this just in case I just can't get a hold of somebody. I don't know, it's just the communication isn't right there and the patient's in the chair. That way it helps me plan a lot more effectively. So you can see that for various types of cancers, head and neck cancers, you have this general idea of where the radiation field is. So at least you can assume, that, okay, the posterior teeth are going to be affected. So I need to be more aggressive in those areas. We want to know the dosage. For head and neck cancers, you can assume it's going to be 50 to 70 for squamous cell carcinoma in the oral cavity. So that's going to be, high risk for osteoradionecrosis, high risk for xerostomia, and all of those things. Of course, we want to know, is there a prior history of surgery? Is chemotherapy going to be on board too? Because radiation plus chemotherapy will give the patient a much higher risk of complications as well. And the type of radiation. Most of the time, patients are going to go through intensity modulated radiation therapy, IMRT. Conventional radiation therapy really isn't implemented anymore because of newer technology. So IMRT does help reduce the radiation dose to the non-tumor sites. So it can help too. But it's nice to know, is it going to be proton beam therapy? That's a newer one that we're seeing as well. Or is it 3D conformal therapy? So prevention for any cancer patient, absolutely, we want to emphasize oral hygiene instructions. We want to have them brush their teeth and the dorsum of their tongue 2 to 3 times a day with a soft or ultra soft toothbrush, and continue performing interdental cleaning. Even with patients going through chemo or hematologic malignancies, most of the time flossing and everything it's safe, unless their platelet counts are extremely low. Then they may consider holding off for a little bit, but most of the time it's safe. So I encourage it. We counsel them on dietary restrictions and things to help promote a non-carcinogenic diet. Like I mentioned, prophylaxis, scaling, root planing is so important. And for your reference here, I put 2 prescriptions for fluoride therapy. So you can use these custom gel carriers, which are the trays we recommend. They're like soft trays that you can put the gel or the Prevident toothpaste right into the tray and just kind of line it, or put a little drop in each tooth, seat the tray, and then clench down into it. Wear that for 10 minutes nightly. Alternatively, a lot of people who are going through radiation and sometimes chemo too, but it's mostly with radiation, that the mouth is just so sore, it hurts so badly that they can't comply with the trays. So we say it's okay to brush with the fluoride toothpaste. It's equally effective. And so with chemotherapy patients, you don't really have to be as, we don't have to be as strict about making fluoride trays, but they should have a prescription 6 fluoride toothpaste. So you should be able to brush with it. But the standard for radiation patients is usually the trays. So, I always want to know, okay, well, for patients who are going through cancer treatments, what should I consider extracting versus not? Back in the day, I was told that patients who are going through radiation, you completely just took out all their teeth because it was just too risky. Today, you can really maintain a good dentition with good oral hygiene, good dental follow-up, despite going through all these treatments. So generally, we have found that if the pocket depth is greater than 6 millimeters, you have too much mobility, purulence, on-probing, furcation involvement, or really severe caries that really extends into the root surfaces, it's approximating the bone gingival line, we recommend extraction. Is there the presence of periapical inflammation? That's a factor. How broken down is the tooth? Is it non-restorable? Is it partially erupted? How compliant is the patient? So when all these things aren't there, again, we push the extraction. And of course, patient motivation is a huge factor too. We've had some people who verbally tell us that I'm not going to brush my teeth very much. I'm not going to follow up. So we have to be more aggressive. And of course, is the malignant osseous disease encompassing the tooth? That's an automatic yes, we remove that. If the RCT, if the tooth has previously been treated with a root canal, we don't recommend retreating it. We recommend extracting it. It's if it's in the field of radiation, or if there's severely compromised coronal structure, or like I said, if the apical disease is within the field of radiation, it's better to extract. Now, the timing of extraction procedure, we recommend at least 10 days if possible before head and neck radiation, ideally 2 to 3 weeks. Chemotherapy gives us a little bit more wiggle room there. So in the maxilla, we generally say the minimum of 5 days before chemo starts, or if it's in the mandible, a minimum of 7 days. Certainly you want to trim any bone margins to reduce sharp edges, try to obtain primary closure, avoid packing any hemostatic agents within the extraction socket. We just want to try to improve the, or I should say, reduce the risk for any postoperative infection. And then, as I mentioned, these lab counts, we want to make sure and confirm that they are within normal range. As long as it's above 1,000, that is fine here. This was from a different paper, so I put 1 to 2,000, but anything above 1,000 seems to be across the board the common number that we want to make sure the ANC is above. So some examples: to treat or not to treat, at least right away. We see a large dental caries carrying a greater risk of pulpal infection. Treat that. So this is, whether we perform endodontic treatment or extraction. If the patient has a symptomatic endodontic lesion, you treat. Scaling, root planing, or prophylaxis, you treat. These are the types of treatments you want to do before the patient starts cancer therapy. These are the things that can wait. So if you've got an asymptomatic endodontic lesion, actually for patients starting chemotherapy, studies have shown that those don't tend to act out, that patients do just fine with that present. So you can be assured that that's not going to cause a problem. If it's got a small caries, like our patient had incipient lesions, those can wait. Surgeries for periodontal treatment, that can wait. And of course, orthodontics can wait. So what do we do during cancer treatment? During cancer treatment, it's a tender time. This is where we really need to consult and be in close communication with the medical oncologist before really doing anything, because we know these medications can alter their blood counts, they can bleed more, they're at high risk for infection. So for those who are actively going through chemo, or let's say the conditioning phase of their HSCT, we want to really just perform emergency care only. And when we need to perform emergency care only, we want to check their labs and make sure we're consulting with them. Or potentially just give palliative therapy, like medications, maybe antibiotics, something to control and give us time. These other things happen, the reason like 0.2, 0.5, those things come into play because some patients are on chemo for 5 years. It could be an oral chemo, or they've gone through their initial phase and now they're on this chemo just regularly for a while. That's a different situation than someone who's not had any chemo and they're just now starting. So it's worth knowing that patients generally feel well about 17 to 20 days after the chemo session, and that's when their lab counts tend to recuperate. So if you have to perform something, do it then. If something with the prosthesis, of course, is an issue, we generally don't recommend them wearing it. But like I said, some cancers patients are treated for a long time. So they may start wearing them if they're feeling well. You want to make sure that that is comfortable. And then if someone is going to undergo anti-resorptive therapy for a malignancy, so they have bone metastasis, so these are our bisphosphonates like Zometa, or rank ligand inhibitors like Xgeva. For when it's implemented for a malignancy, it's a high dose therapy. So they're getting a much more potent medication, they're getting a higher dose versus when they're used for osteoporosis. So in those patients, it's really important to avoid elective surgical procedures because their risk for Amrange is much higher. So consider non-surgical endo or periodontal therapy for symptomatic teeth. Anything that involves direct osseous surgery really should be avoided. Sometimes what we've been doing is we'll remove the crown, endodontically treat the remaining roots, and then put primary closure over them. And that seems to work well when we're really worried that, okay, this just looks like a high risk situation for Amrange. So those are some principles to consider. So here's a patient on that note, is that we saw this nice 70-year-old woman who came for a new patient exam. She came during her cancer treatment because she'd had a fever for a week, and her oncologist thought, maybe this is due to your dental infection. Let's go have them check it out. She had metastatic colon cancer with mets to the liver, hypothyroid, GERD, and anxiety. She had a colon resection in March of 2018, and she was going through this targeted therapy, regorafenib. The nib that is the giveaway here, because it's this particular one is a tyrosine kinase inhibitor. And the regimen is specific for metastatic colon cancer. It's 2 tabs for 21 days, then you hold for 7 days and repeat. And then she's on nausea medication as well, as you can see, and then the other medications for her thyroid, GERD, and anxiety. And, forgive me, these are not the best images that I had, but these were her, she only had the mandibular teeth. So the questions here are, we can definitely see these teeth, I think we can all agree, are non-restorable. She didn't have anything else there. I mean, of course, we could probably patch some, but some of these are really not worth saving. However, we come to a decision. This patient has metastatic colon cancer. She has nothing else to chew on. What we know is that we don't see any periapical pathology that would be causing the fever. So at least we know that part. But it comes into play for us to decide, like, should we put this woman through extractions right now when she's already, her prognosis is probably fair, if not poor, and she has nothing else to chew with. So those are the kind of questions we talked about. But then the next question is, okay, let's say we decide to do those extractions. How does the medication, her chemotherapy, her targeted therapy affect her ability to withstand these dental treatments? So that brings me to the topic of targeted cancer therapies. And of course, we'll lump immunotherapy too in this discussion. So these are drugs with specific molecular actions to specific targets in the cells, and they alter the specific cell signaling using monoclonal antibodies and small molecules. So you can often tell if the drug ends in MAB, monoclonal antibody, or IB, inhibitor. They are implicated for a lot of different cancers. As you can see, even some include head and neck cancers. There's some immunotherapy for that. But all of these medicines can cause so many issues with the oral health. Certainly that they can actually increase their risk for Amrange. So it's not just the bisphosphonates that cause the osteonecrosis. It includes these medicines. Patients will be at risk for impaired wound healing. Certainly, these drugs do cause myelosuppression, so they'll be at susceptibility for infections and thrombocytopenia, dry mouth, oral mucositis, even lichenoid reactions. So it looks like lichen planus, taste problems, definitely, maybe oral pigmentation, and neurotoxicity. So some patients will get neuropathies from these medications. So keeping all that in mind, when you see a patient who's going through chemotherapy and you see them during that phase, or for the HSCT patient, it's immediately after, which again, very rare. They usually don't want you to see the patient immediately after, but emergencies happen. So you want to confirm the chemo regimen schedule, find out when the last session was. That's really important. So if this was yesterday, we know their counts are going to be very low. If this was 2 weeks from now, we may be in a better state. And confirm the labs. The great thing about patients going through chemo, I know that that's not the best term, but I mean, the positive thing is that they have labs drawn every time they go. So it's really easy to access. They can go into their portal. You can call the cancer center. I mean, they have labs ready for you that are really recent. So that is a nice thing. And you want to still ensure that you still have these critical lab values in range, as we can see here. So for the oral hygiene recommendations, we of course want to make sure they're maintaining their oral hygiene as best as tolerable during their treatment. I like to recommend the Curaprox brushes, especially the surgical toothbrush. They're really, really soft, and I've seen it make a difference for patients to tolerate their oral care. And of course, we explain to them regularly replace them. Sometimes you can rinse with water or warm saline while they're brushing. That also helps if their mouth is so tender that they can't tolerate other rinses. Flossing with a waxed or tape floss is also very important, but we do remind them that if they do notice that they bleed too easily, then to lay off until their counts are a little bit better there. Rinsing is a great thing for the cancer patients. And I have on the next slide a list that you can reference for different recommendations that patients can use. Patients do exhibit severe dry mouth, so lanolin-based products are really helpful for moisturizing the lips. So the most famous one prescribed is the neutral rinse with salt, baking soda, and a quart of water. And this really helps neutralize the acid, in the mouth from the dry mouth, from if the patient has emesis. Some people get a lot of thick salivary secretion, so it's just very soothing. Even a saline rinse is fine as well. Calcium phosphate rinses are helpful. Chlorhexidine, they say if there's really poor plaque control, this can be an additional help as well. But of course, with chlorhexidine, we know that this can cause some changes when used long term, so they can cause staining and bad taste. So we generally say stick with 2 weeks. Now, after chemotherapy, we just want to ensure the patient's status. So consult with the oncologist, confirm that they have now been completed with their treatment, their hematologic status is returned to normal, find out if they have gone through a bisphosphonate or other kind of medication that can put them at risk for Amrange. Like I mentioned, that 7 to 20 day rule where patients feel well after chemo. And then, of course, a recall is really important. Most of the time, for at least 1 year, we generally recommend 3 months. And then if they're doing really, really well, maybe 6 months. But most centers will say every 3 months you'd like to see the patient. And of course, if they've had head and neck radiation, you need to confirm, okay, where was or if you're just seeing a new patient who's, say, I had, SCC, squamous cell carcinoma 5 years ago. Well, we need to find out what the dosage and field of radiation is there too. For the HSCT patient, this is, again, a very tender population. You need to confirm the immune status of this patient, request their labs, and request their current treatment regimen post-transplant. Because it's a transplant, they're going to be on immunosuppressive therapy lifelong. The timing of care is critical here. The first 90 days to maybe even 100 days, depending on the person, it's really just emergency care only, supportive care. Maybe at the 100-day mark, you can do a periodic exam and just check preventive measures only. Then some patients by 6 months, like if it was an autologous transplant, they're probably doing better. So they say 6 months, you can start to, do your more routine exams and perform any really necessary treatment, provided that their status is normal. But for most people, it's going to be 1 year. So always consult with the oncologist to establish their immunologic status and their immunosuppressive regimen. If you see them for the first year for emergency care, and then you confirm that after for a year as well. And this is going to be for any dental procedure, because of course, most of anything we do can cause bleeding or infection or bacteremia, I mean. I'll show you some pictures of chronic graft versus host disease, because that is a complication that can happen in this patient. Namely, this patient's going to be at high risk for oral complications. So we'll go through that too in a bit, which is now. So as you can see, there's some commonalities of oral complications between chemo and HSCT. Patients will undergo some oral mucositis, bleeding. For patients who have bleeding, for the chemo patients, during chemo only. If the patients say they had breast cancer, they were treated 20 years ago with chemo, no longer, that patient's not going to be at high risk for bleeding. This is the person who's going through chemotherapy. On the other hand, the patient who has HSCT is always at high risk of bleeding because of their immunosuppressive regimens. And you can see there's a high prevalence of oral complications in those going through HSCT. It's an 80% prevalence. Infections are high in this population, both sides, because of the immunosuppressive qualities of their medication. Chemotherapeutics can cause neurotoxicity. So sometimes patients will have facial pain and will think, oh, it's a toothache or it's not. And it's actually a neuropathy from their chemo. So some things to keep in mind if you don't actually see signs of dental decay or disease that be related to their pain. And of course, the osteolytic medications can put the patient at risk for ORN. Xerostomia is a commonality between both of these, and graft versus host disease can occur in those receiving HSCT. So I'm going to go a bit quicker in this segment here, but we'll show you some good pictures of oral mucositis. This is an inflammatory driven process. It essentially, there's a 5-phase model that Dr. Sonis had created, and you can see that initially the chemo or conditioning regimen or radiation, it causes cell damage, leading to an inflammatory cascade that also ultimately causes painful oral ulceration. You can see the difference between those who are going through chemo and radiation. It's much more severe in those who are receiving head and neck radiation. And then, of course, if you've got chemo on top of that, it's even worse. But the risk factors, of course, are also include poor oral health and dental disease. So really good oral hygiene is actually one of the mask ISO guidelines for preventing oral mucositis. Here's a picture. This was a patient of mine who was going through treatment for lymphoma. And so this was for chemo. For chemo-induced mucositis, the lesions are much less severe than they are for radiation. For radiation, they can sometimes include the entire mouth. But targeted cancer therapies and immunotherapy can also cause severe mucositis. So they look like these ulcerations. They can be large and encompass the entire mouth. Now, there is a stepped approach to oral mucositis management. Initially, of course, what helps prevent that is eliminating any active dental disease, teaching the patient good oral hygiene recommendations throughout their care. That is without a doubt an excellent tool for them to reduce their oral discomfort through treatment. And then it depends on the grade of mucositis. So the higher the pain, the ultimately patients may undergo pain management with opioids, moderate or strong opioids. But before that, we always try all these different things like bland rinses, topical anesthetics, even antihistamines. The Magic mouthwash is a reasonable one. It's got a lot of great things in it. Sometimes, you can implement gel clear, Mucguard or Cafisol, which are surface protectants. And a lot of these companies actually do provide samples for your office for healthcare professionals. So you can go on their websites and check. Now, fungal and viral infections can occur during chemotherapy, during HSCT and after HSCT because of that immunosuppressive regimen. The one take-home thing I always tell everyone is if the patient gets candidiasis or recurrent HSV, it's not going to appear normally. It's going to be atypical. And they're also at risk for deep fungal infections. So as you can see here, this is an example of recurrent HSV in a patient of mine who had a history of squamous cell carcinoma. But after a procedure I did, he came back with these massive ulcerations and it was viral. Valacyclovir took care of it completely. This is from the Burkett's Oral Medicine book, and you can see the immunosuppressed patient with viral lesions that occur in atypical sites. They last a lot longer. You may be more likely to see hyperplastic candidiasis in the patient who's going through these treatments. And hyperplastic candidiasis is the type that you can't wipe off. And like I said, deep fungal infections. These are some regimens of treatments for that. I've got antifungal therapy on this slide right here. Studies have shown actually that clotrimazole, itraconazole, fluconazole, they all work really well. Probably the least effective of these is actually the nystatin. So I like to start with the clotrimazole. We always want to try topicals when possible, but of course for the immunosuppressed patient, fluconazole is actually preferred and can be more effective. These are the antiviral doses for immunocompromised patients. The way I remember it is that you've got your dose. For the immunocompetent patient, it's going to be a shorter length. For the immunosuppressed, I'd probably be doing more like 10 days versus just 5 days. And valacyclovir and famciclovir have better bioavailability. So when possible, I always try to do one of those versus acyclovir. We know that xerostomia is a huge issue for patients. So I do recommend these rinses for not only just oral comfort, but it does help with the dry mouth management too. So warm salt water and baking soda rinses, rinse for 30 seconds, spit out, do this 3 times a day. A humidifier can help next to the bed, sleeping with a propped angle, 30-degree angle. The mask ISO guidelines, so this is the reference I have here. Certainly you can use stimulants, saliva substitutes. These are a whole host of products. We really like Camelix, which is available online. It's made from a green tea extract, which serves as an antioxidant, and really our patients seem to like it. Xylamelts is a nice one because you can just stick the tab in your mouth and leave it in all day. Xerostomia has extra virgin olive oil, which some people really like, or I just say try the extra virgin olive oil. Some people will really benefit from systemic agents like pilocarpine or cevimeline. And lifestyle modifications. It's like most of our diseases is like we can't replace the lifestyle things you can do. So increasing hydration to well past 8 glasses a day, like make it 12 glasses a day. Avoid dehydrating agents, and other irritating agents like spicy foods and sour foods. This is what graft versus host disease can look like. It's going to be more common in those receiving an allogeneic transplant. It looks like lichen planus, actually. This is chronic graft versus host disease. Acute usually happens within the first 100 days. It does reduce survival rates, and it can be systemic. It can, affect various organs like the skin, oral mucosa, GI system, the genitalia, the lungs, liver, muscles, and joints. But in the mouth, you'll see these mucosal ulcerations. So that's why it's important for us to be aware. So that way we can alert their transplant physician too that, hey, we're seeing these things, because graft versus host disease actually happens most often first in the mouth. Chronic disease looks more like an autoimmune disease, and that's why you see these kinds of lichenoid lesions. Sometimes you'll see scleroderma-like lesions like fibrosis and things like that. And of course, patients may get taste changes, the formation of mucoceles like at the palate, even non-gingival soft tissue growths can be a part of that. So the problem is that this does put them at risk for infection, and the doctors can treat them with immunosuppressive therapy, or we can even implement topical immunosuppressives like topical steroids. And lastly, I just wanted to touch on Amrange. I could talk a lot more about this, but hopefully another day. But Amrange is defined as bone necrosis associated with pharmacologic therapy. It was called Bronge in the past because of bisphosphonate use. Now we know that there are many other meds that cause it. But these are the diagnostic criteria: current treatment with a bone modulating agent or an angiogenic inhibitor. You see exposed bone or bone that's probed through an intraoral or extraoral fistula in the maxillofacial region that's persisted for longer than 8 weeks, and someone who has not had a history of radiation therapy to the jaws or metastatic disease, because that would be its own qualification for osteoradionecrosis. Stage 1 involves just exposed bone, no underlying infection. Here's a nice example of stage 2 where you can see purulence, so there is infection. And of course, stage 3 is where it starts to extend into areas that, like into the maxillary sinus, nasal antrum, well into the mandible, and needs potential resection. So with that, I have also included some other references that I didn't list in the slide. So, feel free to go back and read more if interested. One thing, this was Olivia Newton-John's quote when she had breast cancer. She said, "I look at my cancer journey as a gift. It made me slow down and realize the important things in life and taught me not to sweat the small stuff." And I really feel grateful to treat patients going through this journey, because it has taught me a lot, and just about the journey of life and the suffering that people can go through, but the hope and positivity you can give your patients will last a lifetime. So forgive me, I always get emotional about these things. So, but with that, I do conclude this presentation. You have my contact information. You can email me with any questions. Just let me know that it was from this webinar that you'd attended. And then we'll take a Q&A right now.
All right. Thank you, Dr. Patel, for sharing your insight and expertise on this area of dentistry that many might not know how to properly treat. I also posted the registration link for webinar number 2 on this topic in the chat as well. So let's get into Q&A. So we have a question from an anonymous attendee asking if there are any special considerations for those in remission, but still have immune compromised status on Amrange.
Mhm. Yeah, that's a great question. Yeah, that is a medication that is, I too have seen it a lot in our cancer patients, and they're going to be on that for a while. Um, Actually, a discussion with the oncologist on my patient who was on this. The good news is it actually doesn't cause as much immune suppression as some of the other chemotherapeutics. So we're less worried about the risk for bleeding and infection, but nonetheless, it's still proper protocol just to confirm what the patient's recent labs were before you do any treatments. Otherwise, if they're stable, they can still receive pretty much any dental treatment, but we emphasize the preventive things like still prescription strength fluoride therapy because it does potentially cause xerostomia, and it potentially causes immune suppression too. So we want to do that. So all of those preventive things that we talked about earlier would be recommended here. In terms of the aftercare, they should be able to sustain routine dental care just fine with that medication alone.
Okay, great. Thank you. I also have a question from Lisa who asks, is neutral 1.1 sodium fluoride effective?
Yeah, so another really good question. Actually, that's what I mostly use. It's easy to prescribe, it's easy to dispense. It doesn't stain any restorations or anything like that. So it is just as effective for using for fluoride therapy. Mhm.
Okay, perfect. Thank you. Another question from Roya who asks, if they can tolerate the trays, can patients continue or start perio protect therapy during cancer treatment?
That's a good question. I would say, we generally don't use, for perio protect. Forgive me, I'm not completely versed on using that modality, but if it's like a non-invasive tool, and you're right, if they can tolerate the trays, I don't see why not. But generally, we don't do a whole lot during their cancer treatment. So even if they tolerate the trays, our best thing is to reinforce their oral hygiene and have them do their home regimens rather than add any additional treatments.
All right, thank you. We have a few other questions coming in, which we can always answer individually after the webinar, but I do just want to share this one last one from Anonymous. And I think you touched on this a little bit, but do you have any more recommendations or recommendations at all to use for dry mouth?
Mm-hmm. Yes, dry mouth. Dry mouth is hard. I'm not going to lie. That's one of those things that affects people just so severely, whether you're going through cancer treatment or not. But I always try to get them on a regimen that's using something frequently throughout the day. So things I like to implement are gels. Oral balance gel is good. Xerostom gel is good. I love the Xylamelts. I think lozenges are really helpful too. So Camelix has them. TheraBreath has them. Biotine actually it doesn't have the same enzymes that they used to have. So there's a product called Oral 7 that has those. And then don't be afraid to implement pilocarpine or cevimeline, especially in head and neck cancer radiated patients who've gone through radiation. It is actually approved for those patients and can be really effective to help moisturize the mouth.
Perfect. Thank you so much. And thank you everyone to all of the questions and interest in tonight's topic. We do have a few questions still. If your question was not answered, we will work with Dr. Patel and get back to you later this week. And Dr. Patel, thank you so much for your time tonight and this presentation. It was really great. And thank you to everyone for attending. We hope to see you all back here for part 2 on March 31st, and we will be sending an invite in the coming weeks. So have a great night, everyone. And thank you, Dr. Patel.
Thank you. Have a good night.